Tissue approximation is a very important part of minimal access surgery. It helps us to achieve hemostasis and approximate tissues. You can approximate tissues using clips. You can approximate tissues using laparoscopic suturing, both intracorporeal and extracorporeal suturing. All those are very important aspects of laparoscopic skill. And today we are talking about the gadgets that are used during tissue approximation. This instrument here is called a GI stapler, or a stapling machine. It is a 12 mm instrument. Some come as 10 mm instrument, and it uses staplers in different sizes, and they are color coded. Some of them are green, others are yellow, others are blue. The reason you have different color codes is basically that each stapler has many millimeters of tissue approximation. So the bigger the stapler, the bigger the tissue approximation you get. You can use clips on the vault, you can use clips on the CBD, rather in GI surgery, like clipping the cystic duct, the cystic artery, the uterine artery, and any other ducts where you want to achieve hemostasis. The way we use a clip, you hold the clip applicator on the shaft, and you pick a clip, you hold it down and push. Then you grab a clip. If you look closely, you see the clip well housed inside the jaws of the applicator. And imagine if this is your tubular structure. You stabilize the tubular structure, put the clip in place, and hold firm for a few minutes. You can see how nice and secure your clip has gotten. So that is a clip applicator. Then you have this instrument here. It's called a tacker. Tacker comes as a 5 mm instrument. It is designed by Johnson & Johnson. It comes pre-loaded with special type of clips, and sometimes you have 3, sometimes you have 15. There are different types of clips you have within the tacker. And tacker is used mainly to secure mesh. You can secure mesh during hernia repair, laparoscopic hernia repair, laparoscopic pectopexy, laparoscopic hystropexy, colpo, sacropexy, any of those surgeries where you need to fire a tacker to secure a mesh. So you put the mesh into place. You can either secure a mesh onto the anterior longitudinal ligament, on the sacropromontory, or at the Cooper's ligament. Those are the common places where we secure the mesh. So instead of using sutures that will take long, you just fire a tacker in different positions of the mesh, and this will nicely secure your mesh over the area of interest. So it is called a tacker. It comes preloaded, and you can buy it from Johnson & Johnson. We have these 2 gadgets here, and these are called knot pushers. Knot pushers are used for extracorporeal suturing. We have a whole topic of extracorporeal suturing, but today we are going to discuss the gadgets used in extracorporeal suturing, and these instruments come in handy. This is called a Clark knot pusher. A Clark knot pusher is used in extracorporeal square knot. If you have a suture, you want to drive it down the abdomen, you make a square knot, pre-made square knot, and then you can drive one limb of a knot into the area of interest using a Clark knot pusher. It is literally like a finger inside the abdomen. You hook the knot and you're able to drive down the knot into the abdomen. So this is called a Clark knot pusher. It is a 5mm instrument. Strictly for extracorporeal square knots, and these knots come in handy in all types of surgery, especially in deeper structures when you want to close the vault during after a hysterectomy, if during biliary surgery and any other surgeries where you do not or are not comfortable with intracorporeal surgery. And this is a Bandaka knot pusher. Bandaka is a 3mm instrument. That means you need a reducer. Otherwise, you get gas leakage. And the Bandaka knot pusher comes in handy if you're using extracorporeal knots for either free structure like appendix or mentum tube, or free structures like, or rather continuous structures, like if you're tying the cystic duct, cystic artery, or the uterine artery, you can use a Bandaka knot pusher. It pushes a pre-made loop. If I have a pre-made loop, for example, this is a Roda's knot, can use a Meissner's knot or a Mishra's knot, and there are other loops which come pre-made by Johnson & Johnson. But if you have your loop, you push it through one end. Here it has an eye. The Bandaka comes with two eyes. There is one eye is at the head, and there is another small eye at the tail end. So you push the thread through the eye of the Bandaka. It's quite tiny. And sometimes difficult to negotiate through the eye of the Bandaka. Omar, you have better eyes than mine. You can help push the knot through the eyes of the Bandaka. Okay. Once the knot goes through the eye of the Bandaka, then you can push the other end of the knot through the tail end. This is quite a short, all right, okay, it's quite short, but the other end goes through the tail end, so that it allows you to do reverse feeding of the only reason why you have to take it through the tail end is to allow you reverse feeding with a 3mm reducer. And once you've done that, then you can push. Let me have your finger. For example, if this is the free structure, like appendix, you have your loop going through the appendix to the base, then you can use the Bandaka knot pusher to push down the loop. Fasten the loop about 3 times, and the knot is very secure. So that's what this does. This is a Bandaka, this is a Clark knot pusher, and they all helped with extracorporeal suturing. Then we have the important needle holders. Needle holders, just like we do in open surgery, sometimes we need to suture. And when you need to suture inside the abdomen, laparoscopically, we call it intracorporeal suturing. And needle holders come in two handy. They are literally non-insulated instruments, and they come in different types. Some of them are straight, like this is a straight. They have straight jaws. And some of them are curved. This is a curved needle holder. And then the curved are either left-handed or right-handed. You can have a right-handed curved needle holder or the left-handed curved needle holder. And all the needle holders have single jaw movement. All of them have single jaw movement. And if you remember, we said all single jaw movement instruments are tough instruments, so that they can be able to grab the needle perfectly without wobbling. So if you have the needle in good grasp, then you can take a bite and you are able to do nice laparoscopic suturing. So every laparoscopic surgeon should gain good skills of suturing. You can decide to do suturing with 2 needle holders, or you can do suturing using a needle holder and a Maryland. So laparoscopic suturing is a very vital skill, and every surgeon should really work hard to make sure that the skill of suturing is well adopted. So you can do laparoscopic suturing, intracorporeal surgeon's knot, Tambo square knot, continuous knots, the baseball knots, all can be done intracorporeal. So suturing is an integral part of laparoscopy. So these are the needle holders. As I said, they are non-insulated instruments, and incidentally, they are one of the most expensive instruments on the trolley. So if you buy, it's better you buy a good needle holder, a strong needle holder that's going to last long. They are single jaw movements and they lock. They have a locking mechanism. All right, and then lastly, having gone inside the abdomen, it means we have to come out of the abdomen. And we shall talk about a very important instrument called a fascia needle closure. A fascia needle closure. This instrument, you can also call it a port closure. There are different types of port closures, but this is the one I have. A port closure, port fascia needle closure, is used to close ports that are more than 10 millimeters. Any peripheral or accessory port or working port that is more than 10 millimeters should be closed because of the risk of bowel herniation. So how do we use this? We pick the suture and it's nicely buried. Then if this is the defect, you go through on one side, then you release the suture. Then you take a bite from another side of the defect and pick the thread and pull it out again. So it's an in and out. All right. Once you have both limbs of the suture out, you can now comfortably close your port. This is very essential after maceration, because remember, macerator is 15 millimeters and the maceration port must be closed. Or any retrieval port more than 10 millimeters on the periphery, which always has to be closed, so you should always have a fascia needle closure. If you do not have this instrument, you can use a Veres. The Veres can also act as an improvision for port closure. Thank you very much for listening.